I want to thank Dr. Benjamin Kinnear for joining us. He's coming to us from University of Cincinnati. It's actually where I trained and where Dr. Helen Lavelle trained as well. And, you know, Dr. Kinnear, I asked him, I think now it's only a week and a half ago, to see if he was interested in doing a talk for us, specifically because I think we wanted to try to do something non-COVID. And he was actually on a COVID unit and was grateful enough to agree while he was kind of swarmed with that. So he is an associate professor of internal medicine and pediatrics, and also at the Cincinnati Children's Hospital. He's an associate program director for the Med-Peds program and the internal medicine residency program there. And he's done a lot to lead the quality improvement curricula, medical education pathway, and competency-based assessments, for which he's published it quite a few times. And he also was my former chief resident, and the fact that he's still on good terms with me tells you a lot after how much I put him through. So with that, I'll let Dr. Kinnear take it over.
Is not what I wrote on my intro. Anyway, thank you, Ernest. You guys are really lucky to have Ernest. We really miss him. One of the brightest, hardest working residents I've ever been around. So I really appreciate the invite. I appreciate the opportunity to talk about something not coronavirus related, frankly. And we'll do my best. This talk is a talk I've given before, and it was not designed for webinar, but I'll do my best to still make this helpful. So thank you for tuning in. Thank you for taking a little bit of time to learn about this. I hope it's helpful. And you know, having just been on a coronavirus unit for a couple weeks, I know many of you probably are, or it's definitely affecting you somehow. Thank you for all the work you're doing, especially the trainees. And I hope that you're able to stay safe and take care of yourself. So we are going to talk about how can we try to maximize the retention of the things we learn. Strategies to maximize learning and retention. Let me see if I can get my slides to progress. Okay. I don't have any disclosures, but I do want to talk about the why, because one of the biggest hurdles I think people have is even believing that they need to, or they could learn better. And when it comes to the why, one of the first things I think about is the fact that there's just so much to learn. You got a lot that you have to know to be a physician. And I wanted to know, I was talking to some pediatrician colleagues, and I wondered, could we actually quantify how much there is to know to be a pediatrician? How much is there to learn? And we went to PubMed and tried to see if anybody's ever investigated this before, and of course not. Oh yes, Ernest put questions here on the chat. If you do have questions, this is a pretty relaxed talk. Feel free to type them in, and Ernest can pipe in and interrupt me, or just interrupt verbally, and I'm happy to answer questions or have discussions as we go. So anyway, so we couldn't find an article, so I thought, could I use some fake science to try to figure this out? And I went to the American Board of Pediatrics website. I promise I'm going to bring this back to internal medicine. And I said, what does the ABP say I need to know to be a pediatrician? How many facts are there? Could I count them up? And for those of you that have taken your boards or are studying for them, you know that they release a content outline or a blueprint of what they think are the key things to know to pass the boards, which in theory reflects being a pediatrician. So I went to the board outline and I found 25 content domains. So there's at least 25 things that you need to know to be a pediatrician. Well, of course, each one of these domains, which are things that we all are familiar with, like, you know, hematology, neurology, pulmonology, usually they're a rotation named after them. You could explode any of these domains into many more topics. Here's an example. If you look at genetics, dysmorphology, and metabolic disorders, you have several topics under there. There's Mendelian inheritance and chromosomal abnormalities and all sorts of things. And this ABP outline actually gives you these topics, which is great. And if you look at some other ones, just so you can see, there's emergency medicine, kind of things you would expect to find in emergency medicine and critical care. My favorite one is infectious disease, because they keep it simple. You just need to know bacteria and viruses. Just keep it broad, ID. Thank you so much. But if you add up all of these topics that are listed under the domains, it's 325 things. So you need to know at least 325 things. Well, that seems doable. But if you look at these topics, there's still a lot of kind of subtopics that fit under there. If you take any one of these topics, you can imagine there's lots of different facts kind of hidden in there. So I wanted to waste some time and explode those out and see if I could estimate how many facts there are hiding in each one of those topics. So for example, I would take something like poisoning and toxic exposure, and I would say, let me look at my review books and see how many things can I list, how many subtopics can I list that would fit under here. And so this isn't just an example of things that I thought a general pediatrician should probably know about under the category poisoning and toxic exposures. There's 27 here. I did this for several different topics. I came up with an average of about 20 subtopics per topic if you look at all sorts of different domains, okay? But then the American Board of Pediatrics says for each thing that you learn, you need to learn these 4 things: basic science and pathophys, epidemiology, diagnosis, and management. And when I dug into those, I found that on average, there's about 4 facts hidden under each one of these things down here. So if you put all the stoichiometry together for this fake experiment, which I actually did, it's just, bad science, there's 325 topics with an average of 20 subtopics per topic, with 4 tasks per subtopic. That's the epidemiology, diagnosis, management, pathophys, that kind of stuff. And an average of 4 facts per task. So what I came up with was 104,000 facts that you need to know to be a pediatrician. It's a lot of stuff. And I did the same thing for medicine, just because I'm Med-Peds and I wanted to know. And I came up with 142,000 facts. It's a lot of stuff. Doesn't mean medicine's harder, although I think we all know it is. It just means that the content outline was different. And if you're Med-Peds, boy, you're really hosed, okay? So I thought, how long would it take you to really learn this stuff? And most of us learn by doing questions. So what if you're a medicine resident or just a you're an Ernest Fisher self-directed learner faculty member, and you want to do 50 questions every day. Let's say you use MixApp, which I know is very popular, and you do 50 questions a day, which you and I both know you're probably not going to do every day. But if you did, it would take you 2,840 days or 7.8 years to learn all of those 142,000 facts, which is just an incredible amount of information. Now, maybe the take-home message from this isn't that there's a lot to learn as an internist, but that we should have chosen a different specialty, because I decided to look at what would something like dermatology look like. And it turns out the stoichiometry is much more favorable. I only found 1 topic, 2 knowledge domains, and 2 facts per items. So if you look at it, I guess the take-home message is you should probably go into like dermatology, not internal medicine. I'm just kidding. I don't know anybody. I'm looking at names on a list. I'm not banging on dermatology. I apologize. Bad joke. So not only is there a lot to learn though, okay, but you're also fighting against this, something called the Ebbinghaus forgetting curve. Sometimes it shows up in pop culture, or if there's anybody in education on the line, you've probably seen this before. Pimple nice. But this guy, Hermann Ebbinghaus, who clearly looks like the life of the party everywhere he went, decided to do a self-experiment where he tried to see how many things could he remember over time. So this graph, on the x-axis is time elapsed since learning, and on the y-axis is percent retention. And you can see immediately he had 100% of things that he remembered, which is great. An hour later, 1 hour later, he remembered less than half of the things he'd learned. And 1 month later, he remembered about 1 in 5 things. It's just this, you're just gonna forget. Now this was an N of 1. You could say, well, it's not very scientific. That's true, but it's been shown over and over again that similar curves exist across multiple walks of life, different domains of knowledge, all sorts of stuff. So this forgetting curve is the inescapable reality of how we learn. We're going to forget. And I don't think that's shocking anyone, but I don't know that we all realize to what extent we forget information, which is why a lot of the basic science things you learn early in medical school, you can't remember later, even though you spent hours and hours and hours memorizing them. We're just going to forget, okay? Now, one question you might have is, that's great. There's a lot that we need to learn. We're going to forget a lot of it. Does it really matter for my patients? Because at this stage in my career, I'm a member, I just want to know, can I take care of patients? This is a really interesting study. This is a study that came out in 2017 from Tsugawa et al. And their question was, does physician age affect patient outcomes? Does physician age, not patient age, affect patient outcomes? And they, this group often uses big Medicare, Medicaid data samples, and they took a 20% random sample from Medicare, These are adult inpatient populations. And they looked at 30-day mortality, readmission rates, and cost, really high-level outcomes. They looked at almost 750,000 hospitalizations, almost 20,000 physicians. And what they found was that as physician age increases, so each one of these boxes is another decade of life, so physicians under 40, 40 to 49, 50 to 59, et cetera, they found a statistically significant increase in 30-day mortality. They found a statistically significant increase in cost of care, no change in readmission rates. And as they did all this, I'm not a statistician or a psychometrician, but they did try to account for multiple factors such as patient characteristics, comorbidities, severity of illness, physician characteristics other than age, gender, where you trained, all that kind of stuff. So they did try to account for as many things as they could that would be confounding some of this data. Now, they couldn't say for sure what accounted for this, but what's interesting is that one of the things they found was protective against this effect of mortality and cost of care going up with physician age was people who worked high clinical loads. Those of you that are further in your career, I'm only 6 years out of residency, but I'm already starting to feel some of this. You take on administrative roles or you do more research and your clinical time gets sliced thinner and thinner. And this study would suggest that that does put us at risk for delivering worse patient care, at least when you zoom out to 30,000 feet. So what that suggests to me, I can't prove it, is if working more clinically protects you from this decline in patient outcomes, it could be either that you are keeping up more with new things that are coming out, new guidelines, et cetera, and the more you work, the more likely you are to keep up with them. But it also could be that you are forgetting more the less patient care you do. And anecdotally, this fits with what I've experienced. The less patient care that I do, the more I've forgotten things that I once knew. And it takes me more and more time to catch back up when I come back on the wards. So I can't say for sure that that this is connected to that, but it makes you wonder, does this actually get to the level of patient outcomes? So this whole preamble is me trying to make the case to you that it really is important that we do our best to learn this vast amount of information that I used fake science to quantify, and that we hang on to it in our brains as long as we can. So we need to maximize the efficiency with which we learn, and we need to not forget, okay? And I don't know about you all, but I never learned from anybody how to learn. I never learned evidence-based strategies for learning until the last few years when some people at University of Cincinnati got interested in it, and now we've tried to spread it to our residents. But this is a novel thing for me. And it turns out I'm probably not alone. This was a great study that came out last year in the journal Medical Teacher, where they were trying to figure out, is evidence-based learning common amongst health professions education? And their big take-home message was, there's a wide gap between what science has learned about effective teaching and learning and what our health profession students and faculty participants report doing. In other words, if you're here in medicine as a resident, or if you're a medical student or a faculty, you're clearly bright and you clearly know how to learn things. Otherwise, you wouldn't be here. But what if you could learn things better? And what if you could remember them longer? And there were strategies that might help you do that. You just don't know them because we don't teach them in health professions education. That's the whole point of this talk, okay? This whole wasting the first 15 minutes on this is to say there's so much to learn and we can't forget it, and it might affect patient outcomes, and we probably haven't learned how to do it as good as we can, even if you're doing well, okay? So what I want to do, this is kind of weird on a webcast, but I'm going to try it because I do think it's important to reflect. I want you to take 30 seconds, I got a little timer here on my screen, to answer this question either to yourself or if you're watching this with somebody. I'm imagining giant lecture halls full of throngs of people watching this right now, I'm sure. Think about this question. What is your strategy for learning? What specifically do you do to try to learn as best you can? Not just what do you do, but why do you do it? I'm going to pause. I'm going to give you 30 seconds. I'm going to stare awkwardly into the camera while you do that. Okay, hopefully you didn't just check Instagram or something like that. I hope you really did think about it. What's interesting when I've talked about this at other places or even heard other people talk about similar things. If people are honest, most of the time they don't have a deliberate strategy for learning. They have things that they do, I do questions or I do this or that, but they don't have a strategy or a reasoning behind it. If you do, wonderful, then spread that strategy if it works. But for the rest of you, this is hopefully going to provide some kind of strategy for you. So with all that in mind, here are my 2 learning objectives for the next 30 or so minutes. I hope that at the end of this, you're able to reflect on your deliberate approach to learning, which you just did, and I hope you continue to do that after this talk. And the second part is, I hope that you can implement one evidence-based learning strategy into either how you teach, how you learn, or if you're somebody who develops curriculum, into your curriculum. So can you do those things? I saved just a little bit of space at the end where maybe we can reflect on it depending on how time goes. So before we get to the strategies that do work, I want to just take one slide to talk about things that are not optimal. This does not mean these things have no value, because some of them do. And some of them are inescapable because of how our education works. But these are things that are not linked to better long-term retention. Reading and rereading. Clearly, you have to read in medical education to learn a new topic, to revisit topics. But reading the same thing over and over is not a good way to get it to stick in your brain. Highlighting. Everybody knows somebody, or maybe you are that somebody, who has 7 different highlighters, and you're just going through and making everything like a little rainbow. Makes you feel good, makes you feel like you're doing active things, doesn't actually help you learn anything. Can be helpful for marking things if you want to come back to them later and quickly get access to them. But as you can see in this picture, a lot of people probably over-highlight and make that not very useful. So not helpful for long-term retention. Learning styles. Man, oh man, I love learning styles workshops. They are so much fun. You get this little profile of yourself. Really fun to talk about. Has been shown pretty well that it does not help long-term retention. So it's fun to talk about, but it's probably not super useful for learning. And the last thing I'll say is multitasking. When you do decide you're going to learn, just realize that anytime you have something that's distracting you or you're going between 2 tasks, what you're actually doing is task switching, not multitasking. There's a cognitive toll that you pay every time you switch your attention from one thing to the next. It makes me think of like doing CPR, and you're doing your compressions and you stop compressions, and then when you resume, you have to do, I don't know, several more compressions before you get that coronary perfusion pressure back up. Attention is kind of the same way. You're paying a cognitive toll every time you switch. So having email up, having phones on, having the TV on, all those things, while they feel good, and you may think that you're doing yourself a favor, it's probably actually more distracting than anything else. So I'll just get those things out of the way. And before we get to the actual list of things we're going to talk about, I do also just want to say that if you decide to use any of these strategies, be aware that at first they're not going to feel good. And I'll show you some evidence that, in fact, when you're practicing with them, you won't do as well, but they have a better long-term payoff. And it reminds me a lot of exercise. If you're not a runner and you decide to start running, the first several times you run, it is terrible. It hurts, your lungs burn, just doesn't feel good, you're slow. But the reason why people stick with it is because they know there's a long-term benefit for cardiovascular health and mental health and sleep and all sorts of stuff. So you have to trust that there is some evidence for a longer-term payoff, because when you do these things initially, they're not going to feel good. And here they are. 4 strategies. There's several others out there, but I'm just going to stick to the 4 for now for a relatively short talk. Retrieval practice, interleaving, spacing, and elaboration. And what I'd like to do is for each one of these, I just have a few slides where I'm going to tell you what it is, kind of describe it as best I can. And then I'm going to show you just one example study of how they've tried to study this kind of thing, so you kind of have an idea of how they came to these conclusions, and then maybe a summary point, and that's it. So we're going to go through it pretty quickly, but at the end of the talk, I'll give you some references if you want to do some more reading where you can find more information about these things. Okay, so we'll start with retrieval practice. Now, to understand what retrieval is, I do just briefly want to talk about the process of how information gets into our brains. And this model is called the information processing model. It's just a visual representation. So most information actually comes into our brains through 2 channels, visual and verbal. Okay, those are the 2 main channels. And the first stop is called our sensory memory is. Okay, this is a very brief spot in our brain, doesn't hold information very long, just a few seconds. And if you don't do anything with that information, it pretty quickly drops out of your brain. This is why you can, I'm sure this has happened to you, it happens to me all the time, you can drive to work, a drive that you've done dozens and dozens of times, and then when you get to work or when you get home from work, you don't remember anything about the drive. You're just like, oh my God, was I in a fugue state? I don't know. That's because you were taking in all that information and it went into your sensory memory, but when you weren't doing anything with it, your brain just let it go, okay? If you do something with that information, it'll be translated into images and words, and it'll stop in your working memory. This is, I think of it as the playground of your brain. This is where the action happens. And it too is finite. It can only hold so many items for so long. The numbers vary. Most places say about 7 items. I don't know, people have said, when you read about it, several places will say this is why phone numbers are 7 digits long. I don't know if that's actually true or not, but helps you remember it. That's great. And usually it can hold anywhere from 30 seconds, some places say up to a couple of minutes, but it's also finite. And if you don't do something with this information, when you're thinking about it and you're working with information, it too will drop away and you'll forget. But if your brain encodes the information from working memory, it'll land in long-term memory, which is relatively permanent and has relatively unlimited capacity. Obviously, we're not computers with hard drives, but compared to other types of memory, this is relatively permanent and resilient. Retrieval practice is simply the process of taking information out of long-term memory and bringing it back into working memory, doing something with it in working memory, and re-encoding it into long-term. This is what happens anytime you encounter something new, bring it into your working memory, and you say, oh, I think I know something about that. And you pull it out of your long-term memory, smash them together in your working memory, make new connections, and put them back, okay? That's retrieval practice. To me, this is one of the best. This is my favorite strategy. It has the most robust evidence, in my opinion, and I think it's also one of the easiest ones to do. So I can't overemphasize enough how important this is. Now, how do you do it? Lots of different ways. You could do flashcards. You could do multiple choice questions. I know I've mentioned Mixapp a couple times. I don't have any stock with them or anything like that. I know it's commonly used. When we ask each other questions to stimulate retrieval from our long-term memory, like you see Dr. Saul here asking Michael a question, that's retrieval practice. You can simply just, put your chin on your knuckles and do the thinking man pose and try to retrieve things out of your long-term memory. This is all retrieval practice that you can do. Now, let me show you a study on how they've tried to study something like this. This is a study with 120 students trying to learn English prose. Sounds incredibly boring. And they would read the passage and then they would take a test. Sounds pretty standard. And there were 2 groups. In the first group, they got to read the passage twice or study it twice, and then they took a test. The second group only got to read it once, but then they took a practice test and then a test again. Now, these 2 tests were not the same test, okay? So otherwise, they would just be taking the same test twice and they would know the answer. They were different tests, but they were, one is reading the information again and then retrieving it, or reading it twice. Here's what it looks like visually, and the delay, they varied either 5 minutes, 2 days, or 1 week. Okay, so they did these 2 different conditions, and they did different delays to see what would happen. And here's what they found. If you look at 5 minutes later, the people who got to study or read it twice did better. Not a lot better, but better. And this is pretty consistently shown in literature. If you're cramming for something that's coming right up, reading something over and over is really helpful. But with just a 2-day or 1 week delay, which is not very long, the people who did the read test did much better than people who got to read it twice. In other words, that second time around, if you tested yourself instead of reading it a second time, you hung on to that information much, much longer, okay? So as far as how to do it, I said there's lots of ways. To me, it doesn't really matter which one you choose. There's stuff out there where they try to compare multiple choice questions to flashcards or, and the evidence kind of varies, but the most important thing is just that you do it as much as possible, as much retrieval practice as you can, okay? If you do have testing anxiety, first of all, don't ever hesitate to go get help for your anxiety, but also there is some evidence out there that practice questions can help reduce test anxiety if you do have a test coming up in the future, like your boards or something like that. And the last thing I'll say is many of our residents use packages that come with some sort of literature to read and a question bank, like Mixapp or something like that. What I see people doing a lot of times is they read a whole section and then they do all the questions. So they'll read all of infectious diseases and then they'll do all the ID questions and they'll score 90% and they'll think, man, I'm learning so much. And you're probably learning. It's better than doing nothing. But what this would suggest is it's actually better to take the questions first, then read, then do more questions. This is called test potentiated learning. It actually helps you to take questions first. It cues your brain. It primes you to find those knowledge gaps when you read and then take more questions. you will score lower the first time you take those questions, obviously, because you haven't read the whole section first, which is why it feels worse. But long term, if you're playing the long game to help with patient care, you're not studying for a shelf exam that's next week, it's better to do questions first, then read, then more questions, okay? That's retrieval practice. Let's look at interleaving. This is simply mixed practice. It's better to learn things that are different and find relations between them than to block all things that are similar all together all at once, okay? So you'll hear that called blocking. This is blocking. I'm gonna learn topic 1, I'm gonna learn topic 2, then topic 3, and you're gonna, that's how you do it. This is actually how a lot of our education is set up. You do your surgery month, then you do your internal medicine month, and you do your OBGYN month, and things like that. A lot of education is set up in blocks. Might not be the optimal way. Interleaving would be to say, let's chop those topics up, mix them together, so that we can start to learn the connections and see the differences. For those of you, I don't know if Georgetown has this or not, maybe somebody can text me and tell me, but LICs, or longitudinal integrated curricula, especially in undergraduate medical education, are becoming very popular and are a great way to do more interleaving into our curriculum. If you don't know what that is, just look up LIC, or David Hirsch from Harvard has published quite a bit on that. You have a small group that do LIC. Fantastic. That's awesome. I don't know that we actually have an LIC here, so that it makes me sad. Ooh, Sarah Thornton, fantastic. I'm a big proponent of those. So let's see how they've tried to study this, okay? These are a group of undergrads from the University of South Florida, and they were trying to calculate the volumes of geometric shapes, which I have no idea how to do anymore. And basically they got 2 weeks to prepare, and then the third week they took a test. So in this group, the mixers, they would do a week of interleaved practice, a second week of interleaved practice, and then a test. Blockers would do block practice, and then a test. And if you look at during practice, so during those first 2 weeks when they were doing practice questions, the blockers were crushing the mixers, right? Interleaving would seem like it's not as good. But when they got to the actual test later, the people who did mixed practice or interleaving did way, way better. Which again, that going back to that exercise slide, it feels worse when you're doing mixed practice because you're gonna score lower, but you have to trust long-term it's gonna actually be better for your retention. Here's another study. I only include this one because I love the figure on it. I think it's so stark. This is 4th graders. Again, geometry problems. I promise there are a lot of interleaving studies that don't involve geometry. Where they did lots of practice sessions over time followed by a test, okay? And this was the model they had. So you can see the blocked people just did all of A, all of B, all of C blocked together versus the mixed practice folks had it all mixed up. F is just a space holder so they could keep all the times together. It's just like a break period. And here's what they found. Over time, when they were doing both partial practice problems and full problems, the people who did blocked practice did incredibly well. They were crushing it. And the people who did interleaved questions weren't doing as well. But when you look at the time point where they actually took a test, look what happened. The people who were interleaving maintained their level of prowess, and the people who were doing blocked practice had a sharp drop-off, just a huge drop-off. And when they tried to dig into why might this happen, there were 2 major types of errors that they found. There were fabrication errors, which is essentially you just didn't know it, so you made something up, which we all do. And then there was discrimination errors, which you kind of knew it, but you couldn't discriminate between what kind of thing you were looking at. And as you can see, the people who did blocked practice, they had a lot of trouble with discrimination. I like to think of it as, I don't know if you're all baseball fans. I'm a huge Cardinals fan. Sorry what we did in the playoffs years ago, but congrats on the title. It's kind of like if you're taking batting practice, and if all you did was look at fastballs all day long, and then the next day you did nothing but curveballs all day long, and so on. And then you get into a game, and you've got a pitcher who can throw, any number of pitches your way, and that's not how you practice, then you're gonna be up a creek because you're just used to seeing one type of pitch and knowing what's coming. So I think interleaving is kind of the same way. Clearly, medicine is this way. People don't walk in and say, "This is lung day," or "This is infectious disease day." People come in with undifferentiated symptoms, multiple systems involved. So I think this is really important in medicine that as we think about how we learn, that we do as much interleaving as we can, even though blocked practice feels better. That being said, if you're trying to do some focused learning, I think blocking is fine. If you're getting ready to go into the critical care unit and you don't know anything about ventilator management or pressors, maybe it's good spend some time really focusing on critical care to prepare yourself. And I will say, this is the one that really feels worse. It just, because you score lower when you're doing your practice tests. All right, 2 more to go. Spacing. Spacing is all about essentially not cramming, which I think most of us know. If you visit something multiple times in smaller aliquots over time, it's better than cramming it all together at one point. And actually, it turns out that forgetting curve is not all bad, because partially forgetting something can actually be really powerful in linking it to your long-term memory. The other nice thing is, if you forget something, once you relearn it, the slope of the forgetting curve tends to go down over time. So this is Ebbinghaus's forgetting curve. You can see you're forgetting, you're forgetting, you're forgetting. You relearn it, this slope flattens just a little, you relearn it, the slope flattens a little, and eventually it's going to stick longer and longer and longer. So here's an example of how they've tried to show this. 235 undergrads at Colorado. They use 6 groups of 40 students reading a text from Scientific American. And I'll show you a better representation, but basically they had 6 different groups, each with 40 people in it. And here's what it looked like. If the test condition was taking an immediate test, they had 3 different groups. First one got to study something once and then took a test immediately. The second group got to study something twice and take a test immediately. This was the masked study group. The third group got to study once, then had to take a week break and study it again, and then took an immediate test. So very similar to the masked study group, but they had to take a break in between the times they studied. So, forced spaced practice. And what they found was, if you test somebody immediately, the masked practice does that. In other words, if you're taking a test right away, cramming probably works, okay? Distributed practice was no better than studying it once. They did the same thing over again, but the test was delayed by 2 days. This is the wrinkle in the second time around. This was a different group of people, but same set of circumstances. You had the single study group, the masked practice group, and then the spaced group. But now the test happened 2 days later, so you get time to forget. It's not immediate. And this is what the first results showed with the immediate test. The second time around, when you just delay it by 2 days, the people who did distributed practice or spaced just that 1 week remembered a significant amount more. And this has been shown over and over again. So, so the point is that if you're learning something for tomorrow, or you're taking boards tomorrow, or your shelf exam or whatever tomorrow, cram. But if you're trying to learn something long-term, being deliberate with spacing over and over again, and actually spacing it out and revisiting topics is really, really important. It's important to revisit the things you get correct too, although you might want to early on focus on the things you get incorrect. And again, let yourself forget some. This was a really interesting study I just want to briefly talk about, where they tried to actually quantify what is the optimal time to space. And after looking at, I forget, it was like over 2,000 people or something, they created this temporal ridgeline of optimal retention. And on this, I don't even know what you would call this, x-axis, I guess, or y-axis, z-axis maybe. This is the test delay. So this is if your test is a short delay or if you want to be tested a year later. This is the study gap. So how long of a gap do you have in your spacing? And then this is the amount of recall over time. And the point is, it's kind of hard to figure out, this line here is the ridge of optimal retention. And as it skews toward longer study gap, the further test delay you have. So if you are taking a test in a short period of time, like a week, then you want your study gap to be pretty short too. But if your test is in like a year, your study gap might be months. And in fact, their conclusion was the longer the test gap that you have, in other words, the longer you want to be able to retain something to be tested later, the longer the optimal study delay. And for us, as I mentioned, if the thing we're studying for isn't a test that's in a month, but lifelong learning to take care of patients, then we should really be deliberately integrating long study gaps and revisiting topics in a deliberate fashion with month-long gaps in between to try to promote lifelong learning. I see Ernest asking, is systems-based curricula interleaving? It's a great question. So one of the things about interleaving is the definition of exactly how to do it is not known. So for example, if you are learning all pulmonology, there's going to be a little bit of cardiovascular stuff in there. You might learn a little bit of infectious disease when you learn about pneumonia, or a little bit about the immune system if you're learning about ARDS. And And so that is some interleaving that's kind of baked into medicine in general. Nothing is on an island by itself. The question is, how much interleaving is the best amount of interleaving? And I don't think anybody knows that for sure. And one of the things you're noticing is I'm not citing medical education articles because there's not a lot of them out there. And I'll come back to this at the end, but we're extrapolating a lot of this from studies done in graduate school, undergrad, high school, even younger. But it's pretty well accepted in cognitive psychology that these are probably the best ways to learn for long-term retention. Ernest says spacing would be bundles of topics so you could study daily but not come back to that topic for 1 month. Yes, I think that's true. So here's an example of how you could put it into play. This is a, I'm not going to say what company this is, but it's a question bank company that I really like. And one of the reasons I like it is they have learning analytics baked into their questions, where after you answer the question, they ask you this down here: how confident are you? So they're trying to get at, are you guessing or not? And then on the back end on your dashboard, they have this matrix of confidence versus performance, where they break things down by, did you know it and you knew that you knew it? Did you not know it and you knew that you didn't know it? Did you know it but you didn't know that you knew it? And then did you think you knew it but you didn't? So this whole like confidence versus competence overlay, and they do deliberate spacing based on whether you knew it or not, but also whether you were guessing or not, which is just an awesome thing. So they deliberately space things out in a way that tries to revisit things in an evidence-based manner. It's really fantastic. I do think this is not MixApp, but I think MixApp, the latest version, also does that as well. And one thing I'll point out is that spacing and interleaving often go together. It's hard to do one without the other. So if you decide to interleave topics over time, so in a curriculum, then you're almost inevitably going to be spacing those things as well. They kind of go hand in hand. All right. The last thing is elaboration. Elaboration, or sometimes you'll hear it called elaborative interrogation, but I think that sounds a little more aggressive, so I'll just call it elaboration. If you boil this down, it's simply asking how and why. It's not being satisfied with a superficial understanding of something and trying to build connections with other things that you know and that are already in your long-term memory. So let me give you an example of how people can learn something superficially. I'm sure many of you have seen something like this. This is the hyponatremia algorithm that's in every review book and things like that. And I can draw this thing from memory. I'm guessing most of you can draw it pretty well from memory too. But that doesn't mean you actually understand what's happening in there. It still means you might be able to troubleshoot hyponatremia. But if you can't explain the why and the how behind this little flowchart, then you don't really know it. And elaboration is to push yourself to ask those really tough questions while you're studying to help you get a deeper understanding. So these aren't tough questions, but simple elaboration questions might be, how are ADH and urinosms linked? Why is SIADH a euvolemic state? How did the urine findings differ between SIADH and cerebral salt wasting? Why does CHF cause SIADH? Okay, all those different things. I guess it's not SIADH, it's appropriate ADH release, but why would it cause hyponatremia? Pushing yourself beyond the superficial understanding and that illusion of explanatory depth. One thing I'll say is elaboration is really tough with a novice learner, and you've all seen this when you have a medical student or maybe an early resident on rounds, and somebody's asking them elaborative questions and they're just getting stuck over and over and over, and it just becomes beating a dead horse. That is not helpful. That just destroys learner confidence. But the question is, when you yourself are studying and you're doing practice questions, let's say, and you get an answer right and you kind of understand it but don't really understand it, are you the kind of person that asks the why and how questions and maybe clicks on the article that goes with the answer, or do you just keep going because you want to do more questions? And the people who stop and actually learn the how and the why, or they themselves ask how and why if they're just trying to push themselves, will retain this stuff much longer than people who learn it at a superficial level. Here's just a quick study. 8th grade students, they were, again, reading a text, did pre and post tests, and the intervention group, they had to elaborate as they went. So they didn't just read, they had to speak out loud and explain what they were thinking and how they thought things connected. They weren't told anything else, they just had to elaborate out loud. And the control group just got to read. And when you look at the people who were prompted to read out loud, they had a 10% greater gain pre and post from those who didn't. And if you look at baseline tests across different categories of questions, all sorts of different things, even amongst those who were prompted to explain, those who explained the most had the highest gain versus those who didn't explain as much. So high explainers versus low explainers. The high explainers had a bigger jump. This idea of elaborating, just thinking through it and making sure you're making all the connections is really so powerful. Now, as I mentioned a little bit earlier, none of these studies were in medical education. And you could rightly ask, like, how do I know this works? And I can't promise you this works in medical education. I can tell you almost everybody I talk to is pretty convinced this is the best way to learn. There are people who have tried to do some studies and are working on doing studies, but we don't have a robust evidence base in medical education yet. But I wanted to share some anecdotal stuff from here in Cincinnati for whatever it's worth. Again, it's all just anecdotal, so you can throw it out the window if you want. The first story I'll just share is we have one of our education leaders here recently recerted for his ABIM test. And is somebody who classically has done okay on his test scores, not our rock star. This is not me, by the way, but I did have permission to share this. And if you look at the scores, passing scores down here in the pink, whenever this person took it, mean score was right here in the middle, as you would expect. And this person, even though they normally are somewhere right around here, actually landed way down here. And this person, the one thing they did differently is we had been talking a lot about these strategies in recent years, and they said, you know what, I'm going to put my money where my mouth is. I'm going to actually change how I study. I'm going to do all the things we've been touting here with our residents, and I'm going to see what happens. I can't prove that it was the strategies that actually made him do better. Maybe he studied longer and harder because of what he was attempting to do, but certainly he outperformed what he normally does, which is just compelling, I guess. As far as our residents go, this is our PGY3 in-training exam scores from 2001 to 2019. So the percentile nationally of how we do for our medicine residents. And you can see if you go back in the early 2000s, we were down here. And then the thing that changed right around 2009 is when we started changing how we were thinking about evidence-based learning. And we started changing our strategies. And from day one, when our residents come in, we start telling them about evidence-based learning strategies and try to implement this in our curriculum as much as possible. And we've seen this just progressive trend upward in percentile, despite having no change in our average USMLE scores of those who are coming in. So again, I can't prove that it's the strategies that are causing this. Maybe our residents are just getting more keen at studying, I don't know. But one of the things that we have certainly changed isn't necessarily the test-taking abilities of those that are coming into our residency, but we think it might actually be something about what they're learning to do while they're here. And if you look at the delta between early year ITEs and later year ITEs, it too is growing. So there's something happening here. Was there a change in entrance to USMLE scores? No, there was not. So, and if you haven't seen a control chart before, we follow a lot of our education data on control charts, so we know when something is, truly special cause variation. And last year, for the first time, you can certainly see a trend here, but for the last year, for the first time, we had what we thought was special cause variation. Got really, really excited about that. So, again, I can't tell you for sure that this is the case, but it's one of the only things we've done deliberately to change the test taking for our categorical residents. And the last thing I'll leave you with is that all of this is based on assuming that your why for studying is long-term retention. The why should dictate the how. As I've already shown you, if you are studying for something that is just coming up, you're about to sit for your boards, you've got your shelf exam or a step exam or something like that, and it's next, it's like tomorrow, cram. You should definitely cram. And I'm not saying never because you have to, but if you're studying for long-term retention, if you're just doing the things that we need to do every day to keep up our knowledge base, I think these strategies will pay larger dividends long-term than some of the things we're used to doing, like blocking our study topics, reading and rereading, cramming just when we need to cram, not spacing things out over time in a deliberate manner. So that's what I would say. Would you say MOC is actually better for us than Q10-year research? I think that the current the change to MOC, where we're doing aliquots every so often, is better than the 10-year research for many reasons. I don't have any evidence to back that up, but I think it fits a lot better with the concept of testing for learning, not testing of learning. And so I think it all depends on what you think MOC should be. Does it need to be a summative test of how smart you are and that you're competent, or is it a check to ensure that you are doing continuous lifelong learning? And if you think MOC should be continuous lifelong learning, then I think smaller aliquots that are less high stakes and that are more frequent is probably better. Any opinion on exercise helping with retention after learning information? Ooh, great question, Robin. I don't know that. I've seen, you know, in a lot of these books, it'll talk about how sleep and exercise do help with retention, but I don't have the studies offhand. So I believe that. I believe that exercise is helpful for cognitive function and for retention. Certainly sleep most definitely is, especially slow wave sleep, but I don't have any of the data here.
Can you talk about, you know, a lot of it is the learner taking the strategy on, but is there anything you found how you might incorporate it on your rounds or in a conference setting?
Great segue, Ernest. Yes. So what I was going to do, and I guess we won't stop and do this now because it's a webinar and be a little bit weird to stare at your computer, but I'm going to share a few examples, Ernest, on my next slide. But what I would love for you to do, if you take away anything from this, maybe you think you're not buying into any of this, but if you are, even a little bit, just write down on like a notepad or in an email to yourself or something, 3 ways that you could try to implement one of these 4 or a few of these 4 strategies into either how you learn, how you teach, or again, your curriculum. That's what I would love for you to do. Even if you can't follow up on it, what are things that would be optimal if you could make them happen? And I'm going to share just a few examples from me personally, or from here in Cincinnati. This does not mean we do them great. This does not mean this is the right way, but this is how we've tried to be deliberate with incorporating some of these strategies here. So let me start with myself. I already mentioned that there's a particular testing platform that I really like, so I'm much snobbier now about what platform I use for my question bank and my lifelong learning. I want to make sure they have learning analytics. I want to make sure that they are deliberate with how they bring questions back to me and that there's thought behind that. So I usually call up and pester the learning analytics folks for different question banks before I choose one. But I now do all test potentiated learning because I used to read and then test. That's how I would study. I would read the GI section, then I would do the GI questions. I'd score 95% and I'd feel great about myself. Now, what I do is I test, then I read, then I do all the testing. So even though I'm a hospitalist, I recently was like, boy, I really should keep up with all of the preventative care stuff that's out there that's kind of slipping from my brain. Rather than reading that section in MixApp, I took a lot of the questions, did horribly, and then went back and read, and then did more questions. So now I do test, read, test, 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 test. So that's one way that I've changed my personal learning. From a teaching standpoint, I now try to incorporate retrieval practice as much as I can for my learners on rounds. Now, you can do this a million different ways. Classically, we do a lot of question asking on rounds, and that's a whole other topic about how do you ask questions in a meaningful way and how do you create a safe learning environment and things like that. But particularly at our children's hospital, we have giant teams, and it's easy to get lost and not really engage everybody. And there's pretty good evidence out there that everybody retrieves out of that long-term memory at different speeds, and that retrieval speed does not correlate with intelligence. So you can have somebody who's very intelligent who is a slower retriever, and if you're asking questions on rounds, other people may answer, and then they don't get to engage, and then they just, so I wanted to find another way to do retrieval practice, and there's all sorts of tools out there you can use to help you. One of them that I like is called Socrative. Again, I don't have any stock with them, it's a free app that I like using. You can build questions, and your learners can either download the app on their phone for free, or they can log in through a web browser on a computer, and you can create these little rooms where you have questions. And what I've done with a couple of colleagues of mine is we've built up a question repository on an Excel sheet of hospital medicine-based questions, both for medicine and pediatrics. Then when I'm on rounds, I kind of keep a list of things that we talked about or things that we see with our patients, and I go back to that repository after rounds, and I can usually find at least 5, maybe 6 questions that relate to something we saw on rounds, and I upload it for a quiz for the day. And I tell my team, hey guys, quiz is coming this afternoon. Why don't you do the quiz? I'll come back around 4 o'clock before sign out, and we'll just talk through the quiz. And what you can see here is that it's anonymous. You can set it so that people can put their name there. You can make a game out of it. They have all sorts of stuff. But I prefer it be anonymous so people aren't afraid to answer and be wrong. I want people to engage. The whole point is retrieval, not who's right, who's wrong. I'm not asking questions to judge your intelligence. I just want you to do retrieval practice. The nice thing about Socrative is you can actually easily upload things from an Excel sheet. So if you have an Excel sheet standing, you can copy things over and upload it. It's really fast. So there's lots of other things out there you can do it, but I now try to incorporate retrieval practice as much as possible. And then as far as our curriculum goes, our program director, Eric Warm, and his chief residents and his other APDs have really done a great job to be very deliberate with interleaving, retrieval practice, etc. So a good example is our academic half day, which years ago used to just be a series of core medicine topics that we would have a theory burst on and then some small group work, and it wasn't really deliberately thought out. Now, we deliberately revisit earlier half days, so we interleave the content over time. It's spaced out, so you're revisiting things at various month intervals. This is all testing and elaboration. Our residents get reading or a module to do before they come to these half days. And then these small groups are all spent with elaboration, asking how and why. There's not a lot of regurgitation anymore of just tell me what you read or something like that. It's all application, elaboration, and we do these in longitudinal groups. So in theory, you feel safe asking those how and why questions rather than just holding it in and trying to keep on your cloak of competence and not wanting to ask those questions. So again, it's not perfect, but every year we sit down with our rising chiefs and we revisit these concepts, which they hopefully have learned throughout residency, and we say, are we doing this right and how can we do it better? In fact, we just had our meeting with them this week via WebEx, where we said, let's look at these concepts, let's look at what we're doing and see what we can do better. So certainly lots of different ways to do it. So here are my learning objectives. I always like to revisit them at the end, so that way you can hold me accountable if I didn't hit them. I hope now you can reflect on your deliberate approach to learning. I hope at least I've piqued your interest a little bit, maybe. And then maybe you can pick one of these strategies that you find most compelling and integrate it into something that you're doing. I certainly have found a lot of value with it, and I really believe it's helpful. If you want to read more about them, there's lots of different places you can go. A couple of things I'll point to. Dr. Yana Weinstein and Megan Sumaraki are fantastic. They have this website, learningscientist.org. They've got all sorts of things. They've got visual aids that you can download if you want to learn about it and teach others. They wrote this book, Understanding How We Learn, a visual guide. It's a very easy read, very quick. Here it is right here. You can see it's not very thick. It's very visual. It's like made for non-cognitive psychologists to understand things, and it has a lot of the primary literature in there if you want to scrutinize it. And then this book here, Make It Stick, Make It Stick by Peter Brown, was the book that actually got our group initially interested in it. It's a fantastic read if you haven't read it. It's all about how to learn and things like that. So great reads if you're interested in hearing more about it. And I'll just hang on here and see if you have any questions. I see Sarah saying, we would like B to come back to us. We miss her. Over my dead body, Sarah. Over my dead body. You can't have it back.
Hey, Ben, our curriculum, we have like a series of noon conferences, and I think it is interwoven in a way that, it's a different subspecialist every day. I guess, is there, in that kind of format though, it's very passive where someone comes in and listens to a lecture and then walks out. Is there anything that a tweak to something like that? Is it like a question at the beginning related to what they're about to talk about, or is there any tips to how to just tweak something like that?
Yeah, super easy. A lot of times it just takes one question. So let me give you an example of what we've done in half day here. And actually the chiefs are doing more and more with our standard noon reports as well. Let's say you're talking about sepsis that day and septic shock. You can hearken back to an acid-base question somewhere in that case, whether it's if an expert's there talking, have a chief or another faculty member ready to go with a question, why is the chloride high here? And what are you going to do about it? What would happen if you give this person diuretics to the electrolytes? What do you think the urine anion gap would be here, and why? Especially if you've already covered acid base. If you're doing a heart failure question or a heart failure lecture or talk or something like that, talk about cardiorenal syndrome if you did a nephrology case 2 weeks ago. And the point is to be very deliberate about something that they should have taken away from a previous learning experience and interleaving it into what you're doing now in a deliberate way. Because the great thing about medicine is, like I said earlier, it's all interleaving. There's always some kind of connection. The question is, can you be deliberate about drawing that out and elaborating on it? That's how connections are made, because otherwise you can be very passive about kind of seeing those connections but not really understanding them.